Being here today. I would like to go ahead and call the 7th meeting of the House Standing Committee on Health Services to order. We do have a quorum, it looks like, so we're going to go ahead and get started. DJ, please take the roll.
Representative Bratcher. Here. Representative Bray. Present. Representative Burke. Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Dotson. Here. Representative Fleming. Present. Representative Gordon. Representative Holloway.
Here.
Representative Marzian. Here. Representative Neighbors.
Here.
Representative Proctor. Representative Rayburn.
Here.
Representative Raymer. Representative Riley. Here. Representative Sharp.
Present.
Vice Chair Duvall.
Here.
Ranking Minority Member Wilner.
Here.
Chair Mosier.
I am here. Okay, we do have a quorum established to do business, so we'll go ahead and get started. I'll just ask everyone to please silence your cell phones. And do any members have any guests that they would like to represent Wilner?
Thank you, Madam Chair. I wanted to introduce Dr. Charlotte Harris, who's with us today. She is a retired orthopedic surgeon from where she worked in Maysville for 32 years, retired now and interested in health policy. So she's here just to listen in. So thank you for being here.
Wonderful. Welcome. Okay. Well, I'll just welcome everyone who decided to join us today, and thank you for your interest and thank you for being here. And we will go ahead and get started with Senate Concurrent Resolution 9. Senator Meredith is here with us, and you know the drill. Introduce yourself for the record, and I'm excited to hear about your proposal.
Thank you, Madam Chair. Always a pleasure to be before your committee. I'm Steve Meredith, State Senator for the 5th District and also the Senate Standing Committee Chair for Health Services. Here to talk about Senate Concurrent Resolution 9. And I hope this is truly the first step in resolving what I consider a crisis of biblical proportion for our nation. And unfortunately, some members of this committee already heard the spiel from me that we can't afford what's happening to our country with health care. Again, to give you the numbers, $15,000 per capita for health care in the United States. Next closest nation is Germany at $8,500, China at $1,000. We can't be competitive in the international market with that kind of spirit in health care costs. And at some point in time, it's going to crush our nation. And it's already crushing our working families with insurance that they just can no longer afford. And our Medicaid program is just a microcosm of that. When I came here in 2017, the Medicaid budget was $10 billion. And I said then, with 40 years healthcare experience, it's as big as it ever should be. If we improve the health of the population, reduce bureaucracy, get people back to gainful employment, there's enough money there to take care of everybody. Roll it forward 9 years, and now it's over $20 billion. I think one of the best pieces of legislation we passed over the past few years is the Medicaid Advisory Oversight Board. Great dialogue during this summer about how we need to impact this program. Heard a lot of testimony, but probably the most impactful came from Dennis Smith, who is former federal director of the Medicaid program, who was appointed in the George Bush administration. And he kind of gave us a history of how Medicaid had developed and payment mechanisms and how MCOs came to birth. And that was kind of the prevailing method for managed care for the Medicaid program. But he said, we have to do something different, and we do. Now, no one has been more of a critic of the managed care organizations than myself, and I think the numbers kind of speak for themselves. Again, back in 2010, we were spending $2.9 billion on Medicaid, and we had 1.4 of our population, 920,000 of our population on Medicaid. Now it's 1.4 million, a 50% increase, but at the same time, our costs went up 400%. But even that increase in cost, we see great dissatisfaction with providers across the spectrum, not receiving adequate payment, too much bureaucracy, and just general dissatisfaction with the program. We do have to do something different. I know that healthcare is quite complex, but the solutions to this problem are not that complex. Again, very simply, if we reduce bureaucracy, if we improve the health of the population, get people back to gainful employment, we can control this budget. and we have to. It's going to bankrupt our states. As noted, no one's been a more harsher critic of the managed care organization model than myself. But in fairness to them, they're doing what they're supposed to do, and that's increase stockholder equity, increase their profits. And that's not consistent with trying to get maximum outcome out of our Medicaid dollars. Because think again about how they earn their money, how they get their profits. Twofold. One is, you know, that our medical loss ratio is 90%, so they get 10% off the top. Now, they'll argue that, well, we're at risk for that 10%. Well, possibly, but I don't hear anybody complain about losing money on the Medicaid program from administering it. But also, keep in mind, now they have access to $22 billion in funds. What do you think the investment income is off that $22 billion? Can't find a number on that, but I'd say probably conservatively it's at least $1 billion a year. And why shouldn't we put that back into the system? Personally, think we should. What I'm proposing is a different model. And by doing so, going back to the bureaucracy, you know, we spend 30 cents of every dollar on the administration of the program. For rural providers, small providers, it's even more significant than that. I think in some instances it could be as much as 50% of every dollar. Improve the health of the population, we do that by addressing social determinants of care. We all know that 60-70% of healthcare issues are based on those social determinants, but there's not a vehicle to do that. We can't say we don't have the money. We do have the money. We have $22 billion that can be addressed towards that. We just have to direct it in the right way. But to do so, for every dollar we improve the health of our population and we reduce Medicaid spending, it hurts the profit margins of the managed care organizations. So why would they want to go that direction? And I use two examples of this as to why we're not improving the health of the population. One being our colorectal cancer program, great program. They asked for a minuscule amount of funding to go forward. And they've asked for budget appropriation this time that's double what they're currently doing. It's still a small part. But the results they get from that have been phenomenal. Where we used to be the last in the nation, now we're at the upper tier. I think if you want to improve the health of the population, why wouldn't the managed care organizations fund that initiative? And we had a bill 2 or 3 years ago, and Chairman Woman Mosier, it may have been your bill on colorectal cancer, hepatitis C, to make sure insurance companies covered the screening for hepatitis C. Because if we don't, you catch it on the back end, it costs us millions of dollars. So why wouldn't you want to cover that screening? Because it reduces Medicaid spending, reduces profit for managed care organizations. The genesis of this bill is many years in the making, but what's most pronounced now is from our Medicaid Oversight and Advisory Board. One of the findings, one of the recommendations is we in fact have to do something different and explore something different. So what I'm proposing is the development and implementation of an accountable community healthcare organization, which is really a hybrid of 3 accountable care models, but I'm hoping we'll take the best of the best with a new delivery system for Medicaid. This new entity will be a public-private partnership, which is locally owned, not-for-profit, community and healthcare provider driven. You know, just like politics, healthcare is local, and it should be. And specifically what I'm proposing is that we do a feasibility study on establishing a pilot program, a 5-year pilot program, that would be include the Lincoln Trail Area Development District, Barren River Area Development District, and the Green River Area Development District. It's a pilot program. The reason I've selected these 3, obviously I represent many of the counties in this district, but their Medicaid population is about 125,000, so it's good sampling of Medicaid recipients. We also have geographically in that region, you have Elizabethtown down to Bowling Green up to Owensboro, and on the periphery you've got Nashville, Louisville, and Evansville, so we've got good access to care in those particular areas. And with that, I truly believe we can reduce healthcare costs by 30% in the future. And think what would happen if we were able to do that, and that translates to insurance premiums for families. If we could be successful in doing that, we could put over $7,500 back in families' pockets each and every year. And what would that do for our economy? What would that do for our families? It truly can.
Okay. We have a motion and a second on the resolution, but we do have a couple of questions, and I'm going to go to Representative Wilner first.
Thank you, Madam Chair. Thank you, Senator, for this. I'm very excited about this initiative.
Thank you.
You and I have talked in the past with some of our concerns about the MCOs, and you've articulated some shared concerns in your remarks today. One of the main concerns that I hear from the MCOs is that about the MCOs is that they are basically a barrier between providers and patients. And how would this be? I'm for this, but can you help me understand how it would be different with this model where providers and patients would have more direct access to one another?
Well, certainly can, because I think for this model, we had to pay by capitated rates. So now the providers take risk for the patient population. So you eliminate that middle person. I know Co-Chair Mosier has a bill to take care of pre-authorization this session. Under this model, you wouldn't have to worry about that at all. That's eliminated. And that's already a big step towards reducing that 30 cents on the dollar administrative cost that's there. So it's provider driven. They're at risk. Communities at risk. That's what really makes this unique. It's not just providers. Communities have to be at risk as well. Now, anticipate if we get a 30% reduction, then that can stay within that community, that area, for workforce development, education, infrastructure, whatever we need, but more importantly, address those social determinants of health that we say there's not enough money for. There's the money right there from those savings by improving the health of the population.
Thank you. That's very exciting.
Thank you. Representative Marzian.
Thank you, Madam Chair, and thank you, Senator, for this really important piece of legislation and for your passion and your concern for our Kentuckians who really need access to health care, and we need to get up a few notches from the bottom. And my question, I'm reading through your whereas, is that since 2010, we have risen from 900,000 or so to 1.4 million folks.
Yes.
In 2025. So that's about, I guess, 1 out of 3. And it was, I think, maybe due to expanded Medicaid and the Affordable Care Act. Now, didn't a lot of those people have to pay some money, pay a little bit too to get enrolled? So there was a little bit of, I hate to say skin in the game, but there was a little bit that they had to put forth. And does that account for that, or? I don't know.
Well, I'm not.
Thank you for this bill. It's very important.
Well, thank you. I'm not complaining about the 1.4 million. I don't think it reflects very well on our state, but it kind of is what it is. We want to take care of everybody who needs health care needs. But I think the way we reduce the Medicaid budget in part is, again, create economic opportunity to get people into gainful employment where they get commercial insurance. Will that be a substantial number? I don't know that it will, but if we can reduce it by 20, 30%, that's significant in itself. And that addresses another problem we have to deal with is poverty is a driver of poor health outcomes. And it can't rely just on healthcare providers to address those issues. It's got to be community-wide. That's why this is a community-owned, community-based accountable care organization. We want school systems at the table. We want local government. We want law enforcement officials. Even the private sector needs to be there to have some ownership for this. And I would hope that everybody would have a equity contribution. Now that's where folks are, whoa, wait a minute, nobody can do that. Well, school systems, you and I have talked about this. If you have a school nurse program, that's your equity contribution because you're improving the healthy population. So anything you do to truly improve the healthy population, you get credit for that. But you also get to share in the success of that.
Thank you for that answer, and again, thank you for your passion for the caring about Kentucky citizens.
Thank
Really
you.
appreciate it.
Thank you. Representative Dotson.
Thank you, Madam Chair. Thank you, Senator, for bringing this important legislation to the forefront and taking the lead. I know many are working on the House and many are working in the Senate to try to come up with resolutions. With the 1.4 million people who are currently enrolled, have we changed eligibility requirements? Are we going to be able to do that to make sure we get the people who are able-bodied off these rolls and reduce our total outflow when it comes to what we're putting out, $20 billion a year now? So are there any projection of numbers or eligibility requirements that are going into some of these things that we're looking at?
There are, and please allow me to have this opportunity to thank Representative Fleming for the great job he's done as
Yes.
co-chair of Medicaid Oversight and Advisory Board. This is a big task. If we're dealing with those particular issues, one of the great things about this advisory board is going to be much like our pension oversight board. We'll be meeting every month to address each of these issues. We know under H.R. 1 that, this is going to be impacted. Eligibility is going to change for some of these folks. But I hope we don't focus on that as much as truly just economic development so they don't have to rely on Medicaid. There will be a reduction, and I've heard numerous numbers, and I think it's too premature to really project what that is, but since we're meeting monthly, we'll have an opportunity to monitor that closely and see how it impacts our Commonwealth.
Okay, thank you so much. Appreciate it.
Okay, thank you. And then Representative Fleming.
Thank you, Madam Chair. And Senator, thank you very much for your passion and your energy to keep this subject and this topic ongoing. I do appreciate your valuable input and insight on the Medicaid Oversight Board. I know you've been around a bit, but also have a very good, strong health background to provide insight. You know, and I know quite well that the current system is not operating efficiently. We're stagnant in many areas. Not to say that we are excelling in certain areas, but we've got to look at, and this is more of a commentary, not to a question, but we've got to look at different models. We are looking at on the dental services, going to administrative service organization, and what you're proposing, what you're looking at, the Medicaid Oversight Board, we will have to stay on top of it because this is a complex structure. I appreciate the localizing this in order to go through and to provide better services. Just a question, and I do have a question. Is there any idea in terms of the cost to administer this program, and how that would affect maybe the budget? And I'm not trying to pin you down. I'm just
That's
because
okay.
I have not
Yep.
really dived into that. I've got an idea on the dental side, but I really haven't looked at the overall, the overall health and replacing our current model with this model.
Well, that's one of the reasons for the feasibility study. Obviously, there's going to be some implementation costs, but I hope maybe under the Rural Health Transition Grant that we can defray some of the costs there. But as far as going forward, it can't be any more than what the current medical loss ratio calls for. So it says we got a 10% overhead margin to work with, and I think we can do it for substantially less than 10%, particularly if the provider is at risk. Because now, and they say, the risk scares people, but I remind our healthcare providers, you're already at risk, either through reduced payments or no payments. So you're not taking any more risk than what you have today, but now you're incentivized to improve the health of the population, and you'll get rewarded from that. So the overall cost, I don't think long-term is going to be any more than what the $22 billion is today. And we can significantly reduce it. And other states have already done this. This is not new territory. I think there's 12 states that already have some type of accountable care organization model, and 10 more that are in the offing. So it's not a new frontier, but I hope it's something that we can do even better than other states and be a model for the nation. We become a de facto insurance company under this particular model. And what I envision long term is not just one region, but each of our 15 area development districts, we divide it by about 3-4 counties each, but I envision 5 of these across the state. And we will be able to offer this product to the commercial market as well. Particularly if we can show that we reduce healthcare costs. I know we can. And other states have seen some success in this, real success.
Ma'am, just one follow-up comment. A lot of people don't realize, Senator, and I think you would probably agree with this statement, is we are an insurance company in terms of providing services to the least among us. And we've got to think that way, and we need to look at business applications, not saying we're a business, but we need to apply a lot of business applications to how we're operating a nearly $24 billion business in order to make sure the services are delivered efficiently, effectively, and we have the outcome and results that we need to do, because right now we're not cutting it. And we need to take on that responsibility, and I blame part of the General Assembly. I'm definitely look at the administration, and I go back quite a few years, not just with this one, but quite a few years, in order to make sure that the services that we're delivering is being met. So thank you very much for your passion, your energy, and I look forward to getting this on the floor and voting for it.
Well, Madam Chair, if I could, I think one of the things this model brings to the table is innovation. We'll be able to think outside the box. One thing I envision, we're going to have access to data like we've never had before. And I could see the possibility of each Medicaid recipient, we know what we're going to spend on them. And you go to Grandma Duval and you say, we spent $25,000 on your healthcare last year, and you've got these particular health problems. If you will help us improve your health, whatever savings you achieve, you can get to share in that. And you'll get a card that you can use to buy groceries, maybe help the utilities, but that's how we incentivize the general population to be a partner in this as well, because we can't do it by ourselves.
Okay. I love this. The more I learn about it, the more I like it. I love thinking outside the box, not to be cliche, but I mean being innovative and really looking at how we eliminate barriers and address social determinants and the cost. Collecting more data. I love considering that the existing health information exchange and data sharing capacity, all of these systems that we have and are actually working to improve, much through MOAB and the work that Representative Fleming and his team is doing. I mean, I think this makes a lot of sense. I love the fact that it's a feasibility study. We can see how it works.
Well, I've called this project 20 by 30.
I saw that.
And I think really 30% reduction is a conservative number, but I'm trying to be ultra conservative here. So my goal is if we do this by the year 2030, we'll have reduced healthcare expenditures for the Medicaid program by 20%.
Excellent.
I think another thing that makes this a reality for us is the proliferation of AI. It's going to change the way we deliver medicine and can bring efficiency we've never seen before. So we can do this if we commit ourselves to it, and I think we can be a model for the nation.
Okay. Well, thank you so much. I love the creativity and look forward to working on this and supporting this. So, see no further questions? DJ, please take the roll.
Representative Bratcher. Yes. Representative Bray. Aye. Representative Burke. Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson.
Yes.
Representative Fleming.
Aye.
Representative Gordon. Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Yes.
Representative Proctor.
Yes.
Representative Rayburn.
Yes.
Representative Raymer. Representative Riley. Representative Sharp.
Aye.
Vice Chair Duval.
Absolutely, yes.
Ranking Minority Member Wilner.
Yes.
Chair Mosier.
Yes. Okay. Senate Concurrent Resolution 9 passes with unanimous expression, and the same should pass on the House, and I look forward to working with you on this. Thanks very much.
Thank you, Madam Chair, and thank you, members of the committee. You just didn't pass a resolution today. You started a revolution. Congratulations.
I agree. Thank you. Okay, next, we are going to hear another wonderful proposal, Senate Joint Resolution 23. Some of this is should sound very familiar to you. We really want to make sure that this gets through. This is a joint resolution, so it is something that we've heard in this committee before. We just want to make sure that it gets through. So please introduce yourself for the record, Senator Frohmeyer, and introduce your guest and proceed.
Yes, I'm Senator Shelley Funky Frohmeyer, Senate District 24, and let's keep the wellness revolution philosophy flowing here. And with me,
I'm Morgan Bray, the joint employee. Can you hear me now? There you go. Morgan Bray, the joint employee for the Kentucky Hospital Association and Department of Agriculture, doing the food as medicine work.
My name is Dana Feldman. I work for the Kentucky Department of Agriculture as the Executive Director of the Office for Consumer and Environmental Protection.
Thank you. And today we wanted to share the Food is Medicine resolution. And I want to thank Chairwoman Mosier and Chairman Meredith as well. They served as honorary members of our MAHA task force. But I also want to acknowledge Representative Proctor, Representative Callaway, and Representative Duval for also committing so many hours. We never went less than 2 hours in our MAHA task force. And nutrition became front and center, where we recognized rather quickly that food is medicine. And how can we collaborate with some state agencies to really drive that forward? We do believe that nutrition, it belongs in healthcare, and agriculture belongs in the solution. So this is a component of our Rural Prosperity Initiative as well. In Kentucky, we're fortunate truly to have some of the best leaders at the table. So Morgan, I'm going to hand it over to you.
Thank you, Senator Funke Frohmeyer. It's an honor to be able to speak today, and I hope that this is a good news day. What we're learning is simple is definitely not easy. While eating local, healthy, nutritious food grown by Kentucky producers in essence seems like a simple fix, we know that the reality is very difficult. So we are establishing this continuing resolution to build this foundation. So we know that across the board, Kentucky knows that we can feed Kentucky and health outcomes can be improved. So Kentucky Hospital Association has strategically partnered with the Department of Agriculture to lend farmer prosperity as the result of improved health outcomes. And so this is a hand-in-glove partnership for these improved outcomes. So what started with regional listening tours, and it's now coming on the final second year, we're really starting to move to these health outcomes. And so that is absolutely what we expected, but are very pleased to be a part of. And so through shared learning, through evaluation, we have a pulse on hospitals who are taking the autonomy to know what fits their organization and their culture best, and we're very proud of that. And so by supporting this continuing resolution with no budget ask at this point, we are establishing the foundation that is statewide for improved health outcomes. And then just to go over what currently Food is Medicine is targeting, we have clinical interventions, healthcare food service integration, community access models that are involved, nutrition education, as well as workforce wellness. So by taking these buckets, we're really giving the opportunity to address all parts of wellness and increased nutrition outcomes. Finally, the why it matters. Kentucky is still continuing this chronic disease burden that is very high and very severe. And so conditions that are closely going to be expensive are going to also be associated with improved nutrition. Hospitals are always going to see the downstream effect of this, and they daily recognize that this is a long-term improvement that can help with prevention and measurable outcomes. So through creating dependable demand for farmers and producers, we are excited that the rural community support is a positive piece of the momentum that is also coming from Food is Medicine.
Thank you. It's an honor to be here today on behalf of this initiative, the Department of Agriculture and Commissioner Jonathan Schell. This initiative, as you heard a bit over here, is twofold. One, it's to make health outcomes better in our state, which we know is sorely needed, and then also to increase farmer impact and economic development for our rural areas of the state. When we go and we do meetings all across the state with hospital administration and staff, dietitians, farmers market managers, you name it, we're meeting with folks all over the state. Sometimes it's not always the most natural pairing for hospital association and agriculture to be in the same room being connected, but for us it makes the most absolute sense for this initiative because it's a way to incorporate two very important sides of what drives our state and put those together in such an initiative. I do want to say thank you to the Senator for being a leader on this resolution and also to Representative Gordon for doing the same thing in this committee. This, we believe, is the first of its kind resolution in the country, and it means that Kentucky is leading in the Food is Medicine work across the nation and is creating models that are serving for other states and other even federal programs just at this very moment. So thank you.
Okay, we have a motion and a second, and I just want to thank you for your presentation and your work on this. It's very important. I love the conversation, and I think we have one question from Representative Marcia.
Thank you. Thank you, Madam Chair, and this is great. I love this too. And my question is, and I really was looking at the whereas that starts on line 20 on page 1 of 2. and towards the bottom it says making Kentucky citizens healthier by addressing poor diet, food insecurity, and agriculture production barriers, which I love working with the ag department. It's a great idea. Would part of this initiative be looking at health insurance, Medicaid, to cover healthy food? Because a lot of times when you go to the grocery, the healthy food costs more than the junk stuff. So I think what people end up doing is filling up their baskets with tater tots and French fries and whatever. So is there I know it doesn't cover it now, but is there a way that we could move this initiative to say they would cover some of that stuff?
I'll be glad to address that, and thank you very much for your question. So as it stands right now, we do have several payers who are working on food as medicine pilot programs. With these programs, again, this is not a widespread blanket. We are in data harvesting season with no agriculture pun intended. Again, with Kentucky being the foundation of establishing a food as medicine state, we know that work is happening. This is more so to allow us to capture that data, to aggregate it properly, and to make sure that Kentucky leads with a nutrition-focused health outcome with farmer prosperity outcome as well as this work continues. So to not exactly answer your question, it's coming. I think it's advanced and absolutely a goal that we know we have our eyes on.
Yeah, I think it'd be a lot cheaper to pay for broccoli than cholesterol medicine.
And add to that, some of the tremendous work being done at the Appalachian Regional Hospital has been a model and a signal to some of our other hospital networks that if you did show up in an acutely ill situation and you might be in one of the Appalachian Regional Hospitals, you actually go to the cafeteria and have incredibly healthful options. But when you're discharged, you might even be discharged with a food prescription. So this is underway, but it's been at the expense of the hospital. So it has not been picked up by Medicaid necessarily. So there's some trials underway, some tests underway. We're not asking the Kentucky taxpayer to cover that at this point, but we do recognize that prescription may be filled with foods that are produced regionally, locally. Some of that's actually coming all the way from Louisville, which is wonderful for Louisville farmers in that area, but why aren't we growing it in all parts of the state to shorten that distribution? So it's such a meaningful conversation, as you mentioned, Chairwoman Mosier, just getting the energy and the signal out there that we can build a little bit more of a reliable demand for our Kentucky-grown proteins and our Kentucky-grown vegetables and fruits. That's an important, reliable demand signal that we need to put out there for our farmers too. They won't grow it if they can't really truly sell it at a great fair price. So this ties into that as well.
Okay, thank you. And thank you for your question, because as you were talking about the potential for coverage, it struck me that we do have the Double Bucks program through our SNAP benefits, which is actually exactly that, really, but only in our farmers market. So how do we define a farmers market in the produce section of our grocery store? I don't know. So a lot of good conversation, a lot of food for thought, no pun intended. But I don't see any further questions. So please go ahead and take the roll.
Representative Bratcher. Representative Bray. Representative Burke. Representative Callaway.
May I explain my vote? Thank you. I do want to thank you, Senator Funky Frommeyer, for your leadership on the MAHA Task Force, for the work that you did to help us, really hone in on some specific areas. We had some wonderful discussions, very fruitful, that pun was intended, discussions. And, it was interesting to learn even how some of our SNAP benefits can be used at local food farmers markets, all of those things. The extensions, all the programs they have about cooking, fresh food. We're having some really good conversations. Appreciate the work with Commissioner Schell and his crew. Thank you all. So I want to just express my extreme gratitude for, again, your leadership, and I look forward to continuing this. I hope we do more of this. So I'm an enthusiastic aye.
Thank you.
Representative Camuel,
Yes.
Representative Dotson, Representative Fleming, Representative Gordon, Representative Holloway,
Yes.
Representative Marzian, Representative Neighbors,
Yes.
Representative Proctor,
Yes.
Representative Rayburn,
Yes.
Representative Raymer, Representative Riley, Representative Sharp,
Aye.
Vice Chair Duvall,
Yes.
Ranking Minority Member Wilner,
Yes.
Chair Mosier.
Yes. Okay. Senate Joint Resolution 23 passes with favorable and unanimous support. Congratulations. Thanks for your work, and the same should pass on the House floor. Thank you. Okay, so the next scheduled meeting of the House Standing Committee on Health Services will be March 5th. I can't believe we're talking about March already, but we are. And it'll be here in this room. And seeing no further business,